All right, everyone. We're going to change scope a little bit here and talk about not coaching trainees per se, but coaching peers, which really is, it's interesting. Janet, who I'll introduce in a bit, is an executive coach who helps us with our surgical coaching program. And she and I were talking about how there's a lot of similarities in teaching trainees and teaching your peers, especially when done well. They both embrace adult learning theory and embrace our whoever you're trying to teach or coach in an adult way. So I'm going to start a little bit here by talking about why I care about surgical coaching and why I think it's really important from a quality perspective, because unlike the phenomenal educators that you've heard from thus far, I'm not an educator, I'm a quality guy. I'm a surgical safety and quality person, and so I come at this with a little bit different perspective, and I want to tell you that story a little bit before I get into our coaching model. So disclosures, I have funding from NIH and AHRQ. I'm a co-founder of a company called Arbor Metrics, which makes software for profiling quality and safety, which I will not discuss today. And I want to lay the framework a little bit. As I said, I'm a quality person. I spend a lot of my time thinking about how to improve outcomes, or improve quality through improving outcomes. I work through this registry called the Michigan Bariatric Surgery Collaborative, which is a quality improvement program and a clinical outcomes registry across the state of Michigan. It's paid for by Blue Cross and Blue Shield, which is our major payer, and it includes all the bariatric surgeons in the state. And we essentially come together to use this data to improve. And we take this improvement mission very seriously. A lot of quality improvement programs just measure outcomes and report them back, and that's all they do. But we very much believe that weighing a pig doesn't make it fatter. Assessment isn't enough. You have to actually improve the outcomes, no matter what you're measuring. So we feed the pig, and feeding the pig is the quality improvement, and that's what I'm going to talk about next. So as I said, we come together, we learn from our data. This is just an example of what our meetings look like. We meet quarterly and come together to look at our data, which I think is relevant when we talk about the program that we put together, relevant to coaching. A few years ago, we noticed something interesting. We noticed that we were doing QI, mostly around DVT prevention, SSI prevention, and improving these clinical outcomes. What we noticed was we kind of squeezed all the juice out of that. With the low-hanging fruit, we picked. And outcomes weren't getting better anymore. And we decided it was time, as quality improvement professionals, that we needed to sort of get into technique and technical skill and put the surgery back in surgical quality improvement, so to speak. But it's really hard, as those of you who spend your life thinking about how to improve performance. And we did a pilot study looking at surgical skill to see if there was a gap here. It was in the New England Journal of Medicine about 3 years ago now. And I'll walk through that study a little bit because I think it's good motivation for this. So what we did was we had surgeons throughout our collaborative, and we had a very good relationship with these surgeons. They all submitted a tape of a laparoscopic gastric bypass video. We told them to send us a typical case. So what do you think they sent us? Like the best one they'd ever done, with BMIs of like 34.9. I mean, there was barely any fat in these gastric bypass videos. But at the same time, what would that do? That would bias us towards a null finding, right? If we were looking at the relationship between skill and outcome, which is what we ultimately did. And we had technical skill rated on a modified OSATS instrument using a software platform. The video was edited down, so each one was probably 20 to 30 minutes of the key technical steps, the gastrojejunectomy, the jejunojejunectomy, and creation of the gastric pouch. And this is what we found. We found that skill ratings for surgeons vary a lot. They varied from 2.5, which is like an average surgeon, all the way up to one that was 5. The anchor at 5 was master bariatric surgeon. So there was one surgeon in this group that everyone kind of agreed that was a master surgeon. And this is interesting, right? Yeah, it's interesting. It's kind of like a beauty contest. Who looks more slick on their video, right? That's kind of what this shows, which is interesting. But that's not why this study was really interesting. This study was really interesting because we had data on all of these surgeons' last several hundred cases and risk-adjusted data. So we were able to link that risk-adjusted data to these rankings. So we divided these into kind of 3 groups in terms of performance, and we saw how their patients did. And this is what we found. We found that there was a really striking relationship between the surgeon's performance on the skill rating and their patients' outcomes. And, when we first presented this data, people come up and they come to the microphone and they say, Justin, once again, you've showed us the obvious. So better surgeons are better, thank you. But I don't think that's what we showed here. What we showed here was that you can reliably assess skill based on your peers' assessments of your videos, and that rating, whatever that construct is measuring, links to something important. the patient's complication rates with surgery. So it's a much, I think it's a scientific contribution, not a conceptual contribution. We already knew the concept existed underlying that, i.e. that better surgeons are better. So this left us with an interesting dilemma, because as I said, we're a quality improvement collaborative, not a quality assessment collaborative. Merely measuring skill wasn't our goal. And if you think about what methods are out there to improve skill among practicing surgeons, there's not a lot of great things. You know, traditional CME may not be up to the task. Simulators, we didn't feel were up to the task. Dimitri disagrees on that every time I give this talk. He tells me about how they are. Maybe he'll mention that. But we, at this time, at least in our construct, didn't think that was the case. So we went where all good health services researchers go for ideas, the New Yorker, and we dusted off this wonderful article by Atul Gawande from a few years ago. And he raised this really interesting question. He said, why is it that surgeons who rely on a peak physical performance, like athletes who also rely on a peak, don't have coaches, whereas athletes do? Right? Athletes, musicians have coaches, surgeons don't. And I pulled up this quote from his article, which I really like. He says, a traditional learning paradigm tells us there's a presumption that at a certain point, the student no longer needs instruction, you're a graduate, you're done, right? 5 years, you're done, or 5 years in a fellowship, you're done, you're on your own. Whereas in a coaching paradigm, this paradigm considers that teaching model naive about the human's capacity for self-perception, perfection. You know, if you can achieve and maintain their best performance on their own, very much what you'd see. And there's a really interesting cultural thing here, right? We talk about if you get coaching in the OR, how people are going to perceive that. Is this a remedial thing, et cetera? You know, no one says that at Wimbledon. You know, why does Rafael Nadal have a coach? Because no one would think that, right? It's part of the culture. So I think one of the things that we're pushing forward in the coaching movement and peers is really this notion that it's okay to always be giving feedback. That's how you're going to become your best self. This work that Atul wrote about in New Yorker was actually a kind of a lay version of some scientific work that Caprice Greenberg at Brigham and Women's Hospital was pushing forward. She was doing a pilot there, which is where he kind of got the notion to write that New Yorker article. And Caprice since left the Brigham and has gone on to Wisconsin and built a full kind of peer coaching model as her main body of research, working with her research associates like Sudha, who's right there. I say hi, Sudha. Suda's one of the machines behind this. And Caprice worked with a lot of coaches. You know, the coaches you'll notice that she worked with on this slide have changed in football and basketball, but also worked with people from the School of Music and the School of Education to develop her model. And this is the Wisconsin Surgical Coaching Framework, her model here. And a few things you'll notice here that we're talking about. The content is technical and cognitive, and the non-technical skills like leadership. We primarily focus on the technical skills, but one thing you'll find is that you quickly relate, you know, the cognitive and non-technical very quickly are interrelated to the technical side of things. And then the activities coaching, which we'll talk about in kind of much more detail as I introduce the model. Goal setting, motivation, and then developing and guiding forward. Now you'll notice that those are all very similar to kind of the models that you heard for resident education because they're built on principles of adult learning theory. So what is coaching? Coaching is unlocking a person's potential to maximize their own performance. And I should say that the next several slides you're going to see, Caprice sent me. Caprice was supposed to be here giving this talk, but she and Jake decided that they were going to go to the Bahamas or somewhere like that. They're on a beach somewhere right now. So in the spirit of work-life balance, the next set of slides that you'll see here are Caprice's slides, and you'll see them branded with a little Wisconsin Surgical Coaching Program at the bottom. So, definition of coaching, unlocking a person's potential to maximize their own performance. It helps them to learn rather than teaching them, giving them objective and constructive feedback that raises improves their performance and helps them achieve their potential. And this dates back to Ericksons' work, which I'm sure a lot of you are familiar on this plateau of development that you reach kind of in the traditional learning model, especially if you don't have ongoing structure to learn. And you move from kind of this arrested development to an expert performance with something like surgical coaching, when you can get that feedback and enter into those relationships, or we can modify the culture to help that happen. So one of the key things that it's important to define is that we're talking about peer coaching here. And I'll talk a little about the specific program we have. But this is a very different type of coaching than when you have an expert and a learner. When you have an expert learner, there's a very large kind of gradient of what's known. You see that from those videos that we just saw. like, this is a very different activity. You have two people who are ostensibly very good surgeons sitting down, one maybe a coach, one be a coachee, so there's a little bit of implied hierarchy there, but you can't treat it as a hierarchy. That's really important in a peer coaching environment. It has to be non-competitive and goal-oriented, like we heard before, and feedback-oriented. And work outside surgery suggests this is a very important method of improving performance, like in executive coaching, for instance. So with that point, I'll introduce Janet Dombrowski, who's right here. Janet is a professional coach. She's an executive coach, and I had worked with her through a leadership development program at the University of Michigan. And when we started launching this coaching program, we enlisted her to help us think about these coaching model, and then she subsequently hooked up with Caprice and Sudha and helped them kind of fully develop their model. So I'm going to have her go through a few slides here about how she thinks about coaching from an executive coaching perspective. Janet?
Thank you. And so it's been an interesting opportunity to observe peer coaching through the Michigan Bariatric Surgery Collaborative, because it really does challenge the sort of what I would call mental models, at least the ones that I've observed more from the outside than from the inside, of both traditional medical education, but of surgical education in particular. And the two that are probably most obvious is this co-learner versus expert model. So one of the things that's so obvious, and even, I mean, obviously in watching the videos, but even in watching peer coaches when they sit down together, there becomes, even without thinking about it, the person who's designated the coach and the person who's designated the coachee end up in this sort of disparate role already, even if they haven't been chosen for one of the coaches being better than the other. And I think it has to do with the sort of master-apprentice model that has historically been the underlying basis for a lot of surgical training. So that piece is a mental model that we find really is challenging when we sit down with the executive coaches or sit down with the coaches to do coaching. And the other one is the rescue versus responsibility model. And we've got a picture, I'll show you that. It was terrific to hear the previous discussion around giving feedback and different ways of giving feedback. It's a key part of executive coaching, and the constructive part is the key part of it, the specific, non-judgmental, very descriptive, one of my favorites. We listened to a lot of hours of transcripts from these peer coaching sessions. Good hands. I'm sure it's a compliment, I'm sure it means something to somebody, but it is not specific feedback. Maybe something you want to hear, but it's not specific feedback. But it needs to be one of those things that provides the opportunity. Again, I love the reflective, the word about sort of reflective thinking. That's the part that's so incredible, is to have people stop and listen and then internalize and respond. Respond with what their perspective, especially when it's peers. I mean, your peer, if you believe that you're equivalent sort of sitting down there, it's important for your peer to be able to respond back to that feedback. So constructive feedback is a key portion of this. One of the things that's really important, again, that seems different when you're transitioning from sort of this master-apprentice tradition to more of a co-learner tradition, is this shift between what I would call rescue and responsibility. And it takes the rescue piece we saw in that first video. I mean, that person maybe not even been rescuing, they were just doing Oliver said paint by numbers, right? They were just saying, do this, do this, do this. And it's a mental model shift from your belief that this person can't operate without you, couldn't do this without you, that they're not capable. It's a capability issue. And some of that's real, obviously, with early stage learners, but when you're in peer coaching, you have to believe up front that that person has responsibility and that person has capability and they can do those things. So the way you engage in terms of actions is very different when someone is a peer. You're not focused on weaknesses, you're not focused on telling them what to do, you're much more focused on helping them understand what they're doing and why they're doing it. The belief is that people do what they do because they think it's the right thing to be doing, otherwise they'd be doing something different. And that's particularly important when you're talking about peers. It may not be when you're talking about a trainee because they don't know what they don't know. But your peer, you need to make the assumption that they're a responsible person and that it's about building their capacity, not telling them what to do differently. So it's a shift. That's when we've done the work with the coaches. It's the biggest challenge seems to be the mental model shift to get out of that master-apprentice piece and more into a co-learner piece. And these are the three things, and Justin's going to go into a level of detail, but they're very similar to what we talked about before. Active listening, powerful inquiry, and constructive feedback. And they're more important with the peer coaching, I think, in many ways. So.
Great. Thanks, Janet. So that gives you kind of an introduction to the guts of the coaching model and how we think about it. And I want to tell you some very specific example, but I'm going to a couple more things first. So video versus real-time coaching, this is something we talked a lot about in designing our program. But we think video that's the way we ended up going with our program. And I think because it allows the person doing the procedure to actually view their own performance, which you can't really do real time. It's hard to stand back objectively and watch yourself. And we think it confers a huge time savings. And I think the other key thing is that it mitigates any medical, legal, and credentialing complexity for when you're changing what actually happened in the operating room. If you're just debriefing on it and not changing it, I think the surgeon can learn, but you're not threatening medical, legal responsibility. Or have to get into dual consents or things like that. So here we had this data on variation in performance, links to outcomes in our collaborative, and we had Caprice's coaching model. So that we combined those two pieces together and came together and wrote a very large NIH grant in our state of Michigan to improve performance of our bariatric surgeons. We're about a couple years into this now, and I want to give you a little bit of update on where we are. So we essentially selected our coaches as those with the best outcomes. Our surgeons felt very strongly that they didn't want to be coached by someone who had worse outcomes than them. You don't necessarily have to be the best tennis player to be a tennis coach and to be a good coach, but our surgeons didn't want somebody whose outcomes were inferior coaching them, which was kind of interesting. So that's what we did. So in that case, we trained our coaches in the feedback methods, and that's where we brought Janet in to help us with that. And here's an example. We worked with Caprice's group to put together this coach training manual, and then Janet ran our coach training program. As I said, I met her through our leadership development program. And this started in February 2015 with our coach training. We trained coaches over 2 sessions. We asked 15 coaches to participate. Now, only 2 of these are academics. The other 13 are private practice surgeons from around the state of Michigan, some of them 4 to 6 hours away where they had to come in the night before and stay over. And we asked 15 because we needed 12. How many of the 15 do you think agreed to participate? All 15. And they all showed up, and they've still been showing up. For 2 years later, they show up and have a very high level of engagement, I was shocked by that, frankly. This is definitely something where we kind of walked off the edge, and we're hoping it would happen. And then in October 2015, we had our first video-based coaching program. At that point, we had 11 coaches and 11 coachees. Now we have 15, all 15 coaches have coachees, and some of them have multiple coachees. So we're kind of fully saturated in terms of our coaching, and we've been doing it now quarterly since then. And this is kind of what it looks like. We go in, we continue our coach training at the beginning of every session. We give them an update on the coaching principles. We tell them what we learned by listening to their transcript, because we audio record and listen to them. Janet and Caprice and her team, Sudha and Janet and I listen to them and give them feedback on what they need to do to improve their coaching skills. Then the coachees come in, and we have cafe tables just like this. And as I said, there's about 15 tables running at a time now, and it runs before our collaborative meeting. So they come in a few hours early and do this before we have the more broader collaborative. One thing that Caprice's group had designed and that we modified for this, and we use this kind of our framework as this peer coach tool. I'm going to go through it kind of section by section quickly, but I put it in here just so you have access to this.
And we want you to pay attention to this, because when we do our demonstration section, we're going to ask you to volunteer to come up and do some coaching with Oliver, who's agreed to be our coachee for the day. So we didn't print these out for you, but I think between the previous session and this one, you should think about these big buckets of things that are the role of the coach. We're going to ask you to come up and role model that going forward. So forewarned.
And in our coaching sessions, we have this printed up on every table, along with the audio recorder, so they can kind of use it to guide their conversation. We find that's helpful. It's a little bit like a checklist. Not to put too many Gawande things together at once, but a checklist of coaching.
Well, we did 4 hours of coaching training. 4 hours. Now that may seem like a lot to you, 4 hours of sitting through hearing a lot of these kind of things, although you're sitting here for 4 hours today. But for somebody to do executive coaching, I probably went through 4 months of training, like full time for 4 months, in addition to ongoing training. So there's a lot of, it's hard to expect people to learn all these and use them regularly, because they're not necessarily intuitive. So the general framework, as I said, I'm going to go through this kind of quickly, is goal setting. We kind of talked about that in the context of the resident learning. The question here is who's driving the learning agenda, and it should be the coachee. This should be focused on the coachee's needs and not the coach's thoughts. These are some of the things that we learn from our transcript review
mostly that people just didn't, they just kind of dove in and started watching the video together and talking about it, which people find really highly engaging, but we kind of encourage them to slow down and actually think about your goals of the session, both at the beginning and the end, and looking forward to the next session. And then the inquiry. Inquiry obviously is the question asking is a really important coaching activity, is the central to all coaching, and people fall out of this, and Oliver's going to talk about this in his derailers. You know, which hat are you wearing? Are you an expert or are you a co-learner? And obviously we saw lots of room for improvement in this, and we still see lots of improvement, even among our best coaches could improve this. I put these pictures in here because I want to ask you, these are pictures from our coaching sessions. Who do you guys think the coach is? The one on the right. Yeah. Well, it's the one on the right. How about here? Which one's the coach? It's the one on, yeah, you're right. Why? They're listening, right? And it's what's funny is we didn't actually go around and two things you'll see from these pictures. One, everyone's really engaged,
oh, yeah.
right? If you look around, they love this activity. The second thing you'll notice is the coaches are listening, which actually makes me think that maybe our coach training worked a little bit.
Right.
Because we didn't tell them to like pose, pretend like, coach, pretend like you're listening. I just pull these pictures up and I noticed that our coaches actually were listening, which I found was great. And people are highly engaged. We didn't go around and say, look engaged for the photos. I mean, just the fact that these are mostly private practice surgeons, just the fact that the seats are filled, tells you that they're engaged, because otherwise they just wouldn't show up. They vote with their feet. So providing constructive feedback, we talked a lot about that. Making sure that the way that you provide the feedback is sensitive to a co-learner model. And we saw, I think they actually did a pretty good job about this. Our coaches, we're all professionals, and we sit down with people. People are pretty mature by the time they hit their stride in the middle of their life, and we didn't have anyone really being a jerk at all. It definitely wasn't a problem. And then action planning. Who has the responsibility for this? Also the coachee. And this is kind of looking forward to the next session. We heard some good examples of that in the debriefing and the resident side. We definitely saw, between the goal setting and the action planning, these are the two areas that need the most improvement in our own program. So closing thoughts, we think this is a really innovative approach to bring these coaching skills into quality improvement work, and has the power to really improve technical performance in practicing surgeons, which we don't have a lot of great models for that. The teleproctoring that Dr. Duncan does, et cetera. There are nodes of excellence here and there, but culturally as a profession, we have a lot of room to move in terms of learning how to adopt procedures more safely. So that's all I have until later.
Thank you.